Well, thank you for this invitation. It would be difficult to exaggerate how important it is to me and what an honor I felt yesterday in being at least an honorary fellow in an organization that I've admired from a very young age and which I aspired to a long time ago. As some of you may know who were there yesterday at the convocation, I had from college on had my heart set on being a hospital administrator, because I read in Life magazine a full-page ad addressed to parents saying, should your son be a hospital administrator? And that just really triggered an interest of mine. I was always interested in community and social issues, and I was interested in management, and this seemed like a perfect combination. And so I ended up falling into the net of a group of very closely related individuals at the University of Chicago. George Bugbee at that time was in New York, and so I went to see him to find out where I should go for graduate work in the field. And he said, well, you should go to Chicago, which it turned out he was going to lead in about another 6 months. So that was, and he of course had been at the AHA as president and CEO for a long time. And Ray Brown, who was an early worker in this field, and Dr. Bachmeyer, of course. But Ray Brown was still there when I got there. And in fact, he taught the very first seminar class that I had in the first week I was at the University of Chicago. And if anything could possibly illustrate just how much I needed a graduate education in the health field and at the University of Chicago, that certainly had to be it. Because at the very first class, he turned to me and he said, what do you think about euthanasia? And I said, well, actually, I said, I hadn't given it any thought at all. In fact, I said, I don't even know any young people over there. And so I was not off to a promising start. And I won't go any further with what my current beliefs are in that. Anyway, so thanks again for the invitation. It's a personal honor to be here, as well as a privilege to be with all of you. The evolution of healthcare in the United States during the 20th century as a precursor to quality improvements in the 21st century is sort of what I outlined for Deborah as something that I might want to talk to when she spoke to me at the beginning. And so my intent is to review quickly what I think is just the amazing evolution of healthcare in the last 100 plus years. An evolution which I think was what sowed the seeds for what we see today, which I believe we would all agree is a major step forward in terms of our efforts to improve safety and quality of care, something that is focused on now in a way that it wasn't even 20 years ago, never mind 30 or 40. But at the same time, 40 or 50 or 60 years ago, people were working in this direction and set the stage, I think, for what we're accomplishing today and will in the years ahead. So my premise is that today's efforts have really deep roots. And over the last 30 years, it's clear that the society and the economy and the organization of healthcare have been undergoing remarkable changes. And we've certainly seen an further acceleration, really, of science and innovation. But one consequence, I think, of these developments is that in recent years, as a nation, we've sort of observed a new set of relationships in healthcare. Some of them just emerging because of good leadership from people like those in this room and those around the country. But also, we've accomplished a high degree, I think, of professional and organizational realignment. And you're all familiar with the dimensions and live with them every day. But it's striking to me that the stronger healthcare management that has come about, heavily influenced, I think, by this college. It's so impressive to see what's happened here, not just over the last 70 or 80 years, but in the last 10 or 15 years, in terms of bringing along people a little earlier in their careers, making sure that it's inclusive and that it has a big impact in terms of what goes on back in our communities. So that has been a key factor, I think. Also, we've seen new roles and responsibilities, of course, in healthcare and particularly in hospitals, new allied health personnel, closer relationships that we all are aware of between physicians and hospitals in a way that couldn't be imagined even 20 years ago in many cases, and then closer communication among the various clinicians practicing within the institution in a hospital or in a health system. So all of this, it seems to me, these recently developing changes, I think, are going to have a tremendous driving impact on healthcare quality in the years ahead, even though obviously we face tremendous economic constraints and are trying to figure out how to work in that new and not so pleasant environment. So let me begin with the very familiar premise that we've all learned from an early age, which is for any encounter or relationship with a healthcare provider, we expect at the very least to be better off for it, and certainly no worse off. We all know first, do no harm. Very clear that is in our minds. But most of you will recall that effort that went on now in the late, hard to believe this, but the late 20th century, and particularly in the year 2000 as we began the 21st century, where the Institute of Medicine and the National Academy of Sciences gave really serious thought to establishing a committee which would, without any sort of preconditions, would look at all of the factors that were going on and try to identify what were the most critical, and then to establish studies in that area. So in the beginning of the 21st century, the IOM, which is part, of course, of the National Academy, released a report on this groundbreaking medical errors subject, which was the first one we tackled. And the report showed, as you know, that we were doing harm, and that despite the tremendous scientific and clinical progress that we'd made, our overstressed and somewhat loosely organized healthcare establishment too often failed to ensure just the basic safety of our patients. And you may also recall the report received extraordinary attention by the media, and those of you who were in positions of responsibility at that time will remember the tremendous uproar and backlash that occurred. For one thing, the attention was focused on local outlets as well as the national press, both of them combining into sort of a huge storm, if I can put it that way, with lots and lots of local news follow-up focusing on our institutions in communities around the country. And naturally, most of the media's attention was focused on medical error statistics and local horror stories. And the local horror stories were the ones that, naturally I felt a lot of pressure on, because they were, that wasn't exactly what we intended to stir up, but I'm not sure it was a bad thing. Anyway, as committee members, we literally received hundreds of calls, messages of various sorts from worried people around the country, some of them asking, for example, that they should cancel their upcoming hospital admission. Was it that dangerous? We didn't think it was that dangerous, but it was impressive to see how many calls of that sort we got. And the committee, of course, though, went well beyond those sort of dramatic and wrenching aspects and looked at a whole range of issues of scientific and technological and financial and societal development as very important way to assess healthcare delivery and the way it had evolved over the years. From the beginning, the IOM's charge was not necessarily just to examine quality of healthcare, but the broader array of it as it was defined at the time, certainly not specifically medical errors, but quality of care more generally. And in fact, we had quite a rowdy time in the committee over a period of several months over just exactly what should we do about medical errors as opposed to quality of health care more generally. Some members of the committee felt strongly that medical errors were just a very small part of quality and not worthy really of having a separate report. And they were pretty vociferous, and you know some of them, I'm sure. I certainly have never forgotten them. Others thought that errors were actually a leading indicator that illustrated the larger problem, and furthermore, that they would be more easily understood by the public as opposed to more abstract discussion of quality of care, and similarly with respect to legislators, that talking quality alone just wasn't going to pull the wagon. My own judgment is it ended up going to the chair for a decision. It was split that close and that heated a discussion. So my own judgment as chair was that actually both of these views were perfectly legitimate. I did think, though, that the most important consideration was that in order to actually improve quality of care, we had to have understandable and compelling evidence that we as a nation needed systems that were safer, more patient-centered, more effective, and more productive, and that can, which is today familiar. And that can be applied to obviously either errors, which are very much on top of these days in institutions and systems, and the broader question of quality. And I wanted, frankly, the visibility of medical errors to introduce the second report, which was Crossing the Quality Chasm, which came out 1 year later. And I think it's fair to say both of them have been very successful. Most people don't even think about that distinction, but it was thought hard about 10 or 15 years ago. So as we talk about the role of the 20th century in all of this, my premise basically is that during those very turbulent 20th century decades, I mean, if you think back on what kind of a century it was, if you had it, it was kind of hair-raising, and if you had hair, that is, and even if you lived through it, as it turns out. I was privileged to have 60 years of the 20th century, and my parents had the unpleasant 30 years before that, so it was quite a century. But that said, I should say that we came through that century in a very interesting way to get to the current U.S. healthcare system, the then current at the time of this report. Administratively confusing, expensive, cumbersome, often inaccessible, and certainly less than safe or effective. Not because I don't think of sort of intentional poor decision-making or poor management or ill will on anybody's part. My own view is it's just what happens in a large, rapidly developing field, as ours was in the 20th century. And beyond that, if you think about America in the 20th century, the advances that were made, scientific and clinical and economic, were nothing less than heroic, really, when you trace that history, and I'll show you some slides in a minute. But especially considering that the country was very individualistic at the time, competitive, and still quite decentralized. I mean, if you just think back to Medicare, for example, and how difficult it was for Johnson to get that accepted in a number of states, and how much arm twisting he had to do, and obviously was very good at. So as I think about the hallmarks of the 20th century, states' rights, professional independence, local nonprofit institutions, pioneering free market innovation, and freedom of choice, it's clear that that was an environment in which something had to develop that was going to make a big difference in terms of the outcomes for health care. Generally speaking, and this will be very general, it seems to me that healthcare went from basically a lightly regulated or supervised care in hospitals, largely for the poor, and care at home, largely for the growing middle class and the well-to-do, on the one hand, at the beginning of the century, to a very different model of community-based care, which included increased inpatient specialty care and all that went with it, including much higher expectations with respect to specialty certification, peer review, medical records, and the other quality underpinnings that we're so accustomed to today. The response to the IOM reports was really quite dramatic. I mentioned some of the reactions immediately when it was announced. But when the medical errors report, which was 2000, was ready to go public, we were going to release it on a Monday. And we thought as a courtesy we would send a copy of it over to the White House just so they wouldn't be surprised. Well, the White House got a hold of it, the president got involved in it, and the decision was made very quickly that the release would have to be on Monday because the president wanted to announce it in the Rose Garden on Monday morning. This was Friday, and we were planning our press releases and all that sort of thing. So we sped all of that up for to air as human, which was the title of the report. And I ended up in Washington and at the White House on Monday morning, not releasing a press release, but talking first of all in the cabinet room to his cabinet secretaries who had anything to do with health care, which turns out to be quite a few, and then out to the Rose Garden for an announcement, and a lot of reaction in that. And then surprising to me, and he asked me the president asked me if I'd come in to his in the Oval Office and talk to him about it and to explain to him what the issues were. And so it was at that point we already had the endorsement of the AHA and AMA and ANA, and it was pretty clear at the public unveiling that this was going to go forward, although we didn't know exactly what that meant at the time. But I mentioned the reaction, and particularly the president's reaction, as being the first point at which I came to the realization that medical errors and quality of care, as the vice president would say today, so a really big deal. I mean, a really blank big deal. And but he was in the Senate at the time, so he didn't have a chance to say that. Anyway, so the professional associations got on board, and then the report really took on a life of its own. I would say, rather than being any kind of an indictment of health professionals, which was the way it was first interpreted by health professionals, the report really recognized that there was no group or entity to blame. Even more fundamental important, I thought, was maybe the most important thing about the report it was very clear that it was not a bad apple problem. And the idea of it being a bad apple problem was very dominant during the 20th century. And it caused us to overlook what we really should be able to get done. And in fact, as you know, pointing fingers and placing blame is actually counterproductive. So it seemed to be almost impossible to overstate the importance of the idea that there was a broader understanding that emerged that rather than being a bad apple problem like a substance abuse, not to say there weren't bad apples, but that wasn't the problem, that rather to deal with a systems problem, we had to recognize that we were at least 10 or 15 years maybe behind the high-risk industries in attention to assuring safety, for example, commercial airlines or highway standards. And part of the reason, I think, is that we weren't subject to many federal standards. And frankly, nobody wanted to be subject to federal standards. They wanted to be subject to state standards, and that was what the committee, the IOM committee, reported. It seemed to us that state legislation would be required for error reporting, for example, just as states did for reporting deaths from serious traffic accidents or workplace injuries, and to allow a more systematic analysis of causal factors. At the same time, we did recommend federal action in terms of protecting confidentiality for certain information and, for example, near misses, so that physicians would not, and nurses and other clinicians would not be so reluctant. Then we went on making a number of recommendations regarding sort of common system flaws, equipment controls that vary from one manufacturer to another or 1 year to another and get overlooked, or similarly such basic precautions as color coding. We did not call for a national master plan, and the reason for that is pretty simple. It's that that's not the way America works, and certainly not the way the healthcare system works. Rather, we suggested standards, information, and transparency. And finally, we developed a very extensive second report on quality more generally, and the second report emphasized effective and efficient care and taking responsibility for both. For example, evidence-based practice. I mean, these are all things we think of today as taken for granted, but evidence-based practice, interdisciplinary teams, coordination across service providers, communication with patients and families, care processes that achieve best practice, and measurement of process and patient outcomes for purposes of quality improvement. And when you look at organizations today, it's amazing, in my mind anyway, how far we've come. And my impression is that increasingly the overall phenomenon of a culture of quality based on what's best for the patient and which lived every day and organization-wide has had a remarkable and growing impact in communities across the country. In the 20th century, which we've reviewed briefly this afternoon, autonomy of clinical decision-making was a fundamental healthcare value. The IOM committee said, and you would say, I suspect, in the 21st century, a commitment to excellence, including standardization to the best known method, should be preeminent, and always with the patient at the center. And I don't think it's an exaggeration to say in the 21st century that we really have seen a sea change. We've got a long way to go, of course, and we're all working on it. But it's a very different way of thinking than existed even 15 years ago. I'm privileged to serve on the board of Bronson Healthcare Group in Southwest Michigan, and have had a chance to observe this firsthand, and I realize that's not evidence, it's just an observation. But I was thinking, when I was thinking about this talk, about, in chronological order, what had been accomplished since 2000 at that system. And I just made a quick list: customer and service excellence, workforce and leadership development, planning and building a new hospital with the future in mind, physician partnerships and co-location, which of course all came out of the new hospital facility as well, evidence-based medicine, coordination of care, eye optimization, and developing highly reliable processes to improve patient safety, not all that different from the airline industry, probably better, and although with not as few accidents perhaps. So the whole idea, finally, of broadening the geography, which is a very complex subject that you all know an awful lot about, as I have saw it evolving, included not just acquisitions and various collaborations. It was very important to export, if you will, the philosophy and the basic ideas associated with an integrated health system that was very quality-focused and very patient-focused. And I think that's what's happened. So there's no question the challenges are formidable. The political and economic and professional efforts at keeping up with science and discovery, are formidable. But the goals of considering patients' welfare first and coupled with a culture of quality, safety, caring, in my view, not just must prevail, they're prevailing right now, and they will, in the next few decades, take on a very important impact on our country. And I thank you for all that you do, just as a citizen, for making this possible. It's such a contrast to when I did my first assignment in a hospital as an orderly when I was a junior, going from junior to senior year in college, which was the recommendation for how to understand what a hospital administrator did. I thought what the hospital administrator did was kept the books, but it turns out that was evolving quickly too. But that was a memorable experience, and I just shudder when I think about the sorts of things that I was asked to do and the amount of training I got in doing them in terms of patient care, including one on an intensive care unit. It was thrilling as a young lad, but it must have been awful scary for those patients. So thank you for the invitation, and thank you for what you do, and thank you for the college and the tremendous headway that's been made just in the last few years, not to mention the last almost century. Thanks a lot.